Scott, let's turn to the initial therapy of follicular lymphoma. I mean, we have, well, first of all, how do you make the decision about when to start someone? I mean, we've had watch and wait for a number of years, the shelf criteria about initiation. Is that still relevant today? And is that how you're approaching things?
Yeah, I mean, so the GAL criteria is helpful for defining who's entering clinical trials. And so this looks at things like nodal involvement, extranodal involvement, pleural effusions, ascites, leukemic involvement. So I think it helps define the study population. But in clinical practice, there may be people that actually have criteria by GELF that may have treatment indication, but have very slowly progressive disease that you've followed for many years, and it may not be urgent to start therapy. Conversely, there are people that that effectively don't have criteria by GELF that may benefit from therapy. So these might be older folks that have comorbidities. You may want to treat them as they have lower volume disease. You might be able to get away with, say, rituximab monotherapy. So I think the GELF criteria is very important for defining who's entering trials. But in the real-world practice, there's a spectrum of who you're starting therapy on in our patients.
That conversation that goes on with the patient, I mean, I know that my patients, sometimes just the thought, telling them up front, we're not going to treat you for a while, and they most of them think that's crazy, right? I mean, everything they know about cancer is early initiation of treatment is the key outcome. So, but then once you watch and wait them for a while, sometimes it's hard to get them out.
Yeah.
So how does that conversation go, and what criteria you're using? And I guess talk a little bit about how you're deciding what treatments to use in an individual patient.
So, I mean, I think if we think about CLL, for instance, the data suggests that really we should be having active surveillance until disease progression or just before disease progression. We do have data in follicular lymphoma of treating asymptomatic low volume, and that data primarily is using rituximab monotherapy, not a prolonged course, but perhaps eight treatments over 9 months or so. And so for a select population that has questions about delaying therapy, I think monotherapy rituximab, we have data to support that. I think the majority of patients, if you kind of have a back and forth discussion and you see them, I typically see patients frequently we go over the diagnosis, bring them back in, and if they feel great and you have a repeat scan or repeat exam suggesting really stability in their exam, oftentimes they come around to the idea of active surveillance. And patients can have very indolent processes and not require therapy for 10 years in some instances, and very low indolent lymphoma. In terms of choosing treatment, it really depends on the pace of progression, perhaps the histology, so that whether someone has a more indolent appearing low grade versus certainly 3B would be treated more like aggressive lymphoma. And it's really all about comorbidities and selecting toxicity profiles for the individual patient.
So Jay, what about, is that similar to your experience? And then talk a little bit about we'll get into details later about some of the different chemotherapy regimens, but are you using some of these comorbidities or patient factors or even measurement of disease to determine what your frontline therapy is?
Right. I'd first just echo that I think observation is, at least in 2 randomized trials, has been shown that does not treating asymptomatic patients doesn't improve overall survival. And I think as we know that this is a long game disease, I'd sit down with my patients and I say we're playing the long game, the 20-year game here. We're not. We can always get people in remission, but that may not be the most important thing. So observation is really key, I think. However, when patients either meet GELF criteria, there's other reason to treat them. We'll often stratify them by comorbidities. I think we probably do this a little more informally. There are these comorbidity scores, Charleston's scales, but it's really more informal. And then we look at their disease burden. And typically for those that have high disease burden, it's more of, in this day and age, a chemoimmunotherapy approach. And for those that have low disease burden or significant comorbidities, we may try a single agent rituximab strategy.
So chemoimmunotherapy, do you have people call you up and say, what's your go-to therapy for patients with follicular? Do you have a go-to therapy, or is it different for everybody?
Well, I think things may change in the future. In general, it's still bendamustine rituximab frequently. There are data obviously with R-squared, so that's a consideration. But bendamustine rituximab, and it's important to make sure that you're fairly certain there's no transformation. you need to only use it for grades 1 and 2 follicular lymphoma, since, as you know, the 2 randomized trials excluded the grade 3As. So there are certain criteria where you consider bendamustine rituximab, but that's typically what I would go to in those specific situations.
How about Nathan? We're going to talk about the R squared regimen a little bit, but patient selection for different regimens, is it you sort of follow a similar algorithm?
Yeah, I think the buzzword really about newly diagnosed low-grade lymphomas, I think, is individualization of therapy, and you find some patients that they prefer an IV regimen, they kind of finish quickly. Other patients are looking for some type of immunotherapy. I have many of my young and very active patients who actually opt for R squared because of the quality of life, and many of these patients really have almost no symptoms as they're going through therapy. So I would say, unfortunately, I don't have a real clear answer for that. I use R squared in some patients, a little bit of bendamustine, and R-CHOP in patients who are maybe a little worried about something bad that's kind of cooking. And I saw there was an interesting abstract by Dr. Zuka at this ASH where they had long-term follow-up of a SAC trial where they're randomizing patients to get 2 or 5 years of rituximab. And although there wasn't a big difference, one thing I found really kind of interesting out of that abstract, they look at the long-term survival of these patients who were started on rituximab as a single agent. It was 80% at 10 years. And that's very similar to PRIMA trial and some of these other trials that started with chemo. And so I think it brings up to me a very interesting question. If we start with milder therapy first and only use more aggressive regimens like chemo regimens in those patients where single agent rituximab did not work, we may be having the same long-term outcomes. And again, I think in the U.S. we don't use a lot of single agent rituximab as a frontline, but I think in Europe they're more used to using that, and it may be just as good.
Right, and I think this is maybe a situation where the community docs are actually ahead of the curve compared to us academicians, because in the community, I think very commonly, even if you have high tumor burden disease, single agent rituximab is often employed because of the toxicity profile, and people see how much mileage they can get out of that, knowing you could always add in lenalidomide or add in bendamustine later.